Good morning, everyone. Good morning, and thank you for making it for our KOL meeting, Peripheral Artery Disease Day. So thank you for the ones that are here in presence and also for the webcast guests that are dialing in. We're going to have a very interesting day. We have with us two KOLs, Dr. Lantis, which is going to discuss the clinical application of CLI and PAD, and Mary Yost, which is going to discuss the market access and how PAD market looks like. My name is Yaki Anai. I'm the co-CEO and president of the company. Thank you for joining and enjoy the day.
Hi, this is Tim McCarthy from LifeSci Advisors. Thank you for joining us. Joining us today is Dr. John Lantis from Mount Sinai and Mary Yost from the Stage Group. Dr. Lantis is the Vice Chairman of the Department of Surgery at Mount Sinai West, where he is also the Chief of Vascular and Endovascular Surgery and the Director of Clinical Research. Mary Yost is the co-founder of the Stage Group. Since 2010, Mary has been on the faculty of the new Cardiovascular Horizons meeting, lecturing on PAD prevalence and economics. As a reminder, this event is being live webcast. If you're listening via webcast, you can submit your questions to questions@lifesciadvisors.com. And with that, I'd like to invite our first speaker to the podium, Dr. John Lantis.
That's Mary's.
Wait.
Oh, sure. Can you read?
President, CEO, and IT support. So I'm here to sort of set the stage, I guess, as to the problem and why we need help as clinicians and why Pluristem's technology may be very beneficial to us in the future. Critical limb ischemia is a very large problem, but pretty much underrepresented or under-recognized in America. This is fundamentally arterial disease as it occurs other places than the heart. People who have this disease in their heart also have it in their legs, they have it in their carotid artery, their neck, and they have it in a variety of other locations. But most people, not clinicians, but most of the lay public thinks of it as being in one place, but it's a diffuse disease that occurs throughout the body. And fundamentally, it's arterial plaques created by fibrous and inflammatory deposits within the media or the muscles of the small arteries. The risk factors are many. They include smoking, diabetes, being overweight, and general cardiovascular risk factors, including hypertension, and sort of the American lifestyle as we know it. So critical limb ischemia specifically refers to having a very advanced stage, and you're going to hear a little bit about having an earlier stage in a study that Pluristem has done looking at the beneficial outcomes in an earlier stage of hardening of the arteries in the lower extremities. But critical limb ischemia really discusses the fact of having such severe disease that the person is at risk of losing their limb. And this is defined usually by 2 weeks of rest pain. So what happens is the person takes away gravity, picks up their foot at night, puts their foot at the end of the bed, their foot starts to hurt. And often they don't figure that out, and the family says, oh, your foot hurts, let's raise it higher, and it hurts more. And the nurses say, raise it higher, and it hurts more. But it turns out that they have very low blood flow. They'll also, after time, have such little blood flow to their leg that they start to develop an ulcer in their leg, or gangrene, a small hole in the leg. And they usually think, I hit this on something, I did something, because none of us are structured to say, gee, I woke up and I just ran out of blood to my foot, and now it started to die. We don't think of it that way. But that's actually what's happening. And this goes on to create a problem where within 1 year of starting with these symptoms, about 15 to 25% of the patients could go on to have an amputation. And once you have an amputation, your mortality rate starts to increase dramatically, and obviously your costs, because now you can't get around easily. You may get an artificial limb, but really these people are often so ill that they can't also ambulate with an artificial limb. So the 40% increased effort it takes to move around once you've lost your foot, just one foot, but 40% increased effort, their heart's not strong enough to get around either, so they don't do well with this. So the goals of therapy are to bring new blood supply to this limb to relieve the symptoms and to create an environment in which the patient can continue to function well. The other thing that's not recognized about critical limb ischemia is the mortality associated with it. So if if all of a sudden your mother had breast cancer, there's a good chance you'd fly to California to be there with her. You'd call several times. Your sister would fly out there to be with her. If your father had colon cancer, the family would get around. They'd also know that this was a long-term process. There was going to be surgery. There was going to be chemotherapy. If mom has a little hole in her foot, and she's a smoker, she stops smoking. Mom stopped smoking. And she's taking antihypertensive. And she has a little hole in her foot, it's going to heal. Why is it not going to heal? Well, guess what? Ischemic ulcer, mom has a much higher chance of dying in the next 5 years than if she had colon cancer, if she had Hodgkin's, if she had breast cancer, or if your dad had prostate cancer. We're very good at curing these cancers. Arterial disease in general, the only two cancers that have worse prognosis with a 86% and 97% mortality over 5 years are lung cancer and pancreatic cancer. But having a critical limb ischemia ulcer, you have a 55% chance of dying in the next 5 years. So a very significant problem. People just don't get quite how serious it is. So how do we fix CLI? Oh, it's easy. Well, actually, in some people, it kind of is. The only level 1 evidence says revascularizing the patient, bringing them new arterial flow, is the real treatment, which is great. Does that work for everyone is the question. Does everyone do well with this? No. The answer is it's not right for everybody. But it's the best thing we have. And it can be very morbid, and I'll show you that in a moment. So taking a look at one large real-world group, 1,414 patients who had peripheral vascular interventions. Now, these were interventions done without surgery. These were not incisions. This was half of what I do. Putting balloons down people's legs, inflating balloons, putting stents in, doing atherectomies, all comers, all technologies. Well, if you take these 1,400 patients, at 1 year, 80% of them are still alive. 71% are alive with a limb. And when you say freedom from major amputation, what's the difference with that? That's actually losing the entire foot. So you get down to about 64% of the patients you started with actually are alive with their foot on. So 36% of the patients are not doing well within 1 year, even when we intervene. So obviously intervention works for some. 2/3 is not a bad number to kind of keep in mind. Well, what about bypass? Back in the early portion of this century, we participated in Prevent 3 study, which is actually a prospective study, which was run looking at a drug, and that didn't work out so well. But it's actually the best study we have looking at how patients do after bypass for true critical limb ischemia. 1 year survival for patients who underwent a bypass from their groin, taking a piece of vein and taking it down to somewhere below their knee. Their 1 year survival was 84%. Primary patency speaks to having a bypass that works and you didn't have to do anything to it. For that year, you didn't have to go in and touch it up. You didn't have to angioplasty it. You didn't have to take them back to the OR. Only 61% of the patients who underwent bypass still had an open graft without having had to do something else. If you did something else, that's the primary assisted patency. That means you keep them going. And secondary patency means they actually stopped working completely and you had to do something else. New bypass, something of the nature. And you can see limb salvage about 88% out of the group who survived. So again, about 65% total. And this was a very similar size study, 1,400 patients, real world, critical limb ischemia, and this was done at 30+ centers of excellence. This was at Columbia, Duke, it was when I was at Columbia, I participated in this, Albany Med, etc. These patients had tissue loss, and this is the type of patient that the study you're going to be hearing a little bit more about is looking at. Patients with critical limb ischemia and tissue loss. What you see in this slide is just what's been happening over the last 20 years. The number of bypasses has been going down in the United States with an exponential increase in the number of endovascular interventions. Partially that's because endovascular interventions, balloons and stents, don't last as long as a bypass. When a bypass works, it tends to work for about 5 years. Interventions seem to work a little less, so we have to redo them, a lot of cost. Interestingly, though, if you look at this line, this is the number of amputations that are going on. Amputations are not exponentially decreasing as interventions are exponentially increasing. So obviously we need adjuncts. We need something to help us. That sometimes when we do an endovascular intervention, we do a pretty good job, but not a perfect job. And that's another place where we might need something like a stem cell therapy or pluripotent type of cells therapy. We actually have predictors of bad outcomes. We have a pretty good sense who's not going to do well with surgery or percutaneous intervention. The problem is we don't have another option. We kind of like we have this or this for your mom. which one are you going to do? There's actually a large study going on in the United States to see if one of these is better than the other, which is probably not a great idea because for some patients one's better and some other patients and others better. So it's really comparing apples to oranges. But we know that patients who are on dialysis, which is about 30% of my patients who have tissue loss, patients who are older than 75, patients who have anemia, and patients who have advanced coronary artery disease are very bad candidates for open surgery. But sometimes that's the only option really available to them. And we know that patients who are going to have something that's done interventionally, if they're still smoking, they have identified predictors from the PREVENT trial. There are a variety of other predictive indices out there. We're not going to get into those today. But there are ways of kind of indexing these patients and saying, we're pretty sure they're going to do bad. We applied one index, I was telling the story last night, we applied one index to our population undergoing bypass. And if you actually applied the index and said the patients who had a greater than 33% chance of failing an intervention shouldn't be done, we basically wouldn't have any patients in Upper Manhattan because everybody's over a certain age, everybody has to go to a skilled nursing care facility afterwards, and nobody can walk well. And those were the indices, let alone diabetes and renal failure. So right off the bat, we need better things. Now, this slide could be confusing, but what happens in the U.S. at the moment is about 85% of the patients we see who have this disease process get an intervention. About 15% really don't have any good way of doing an intervention. There's not the right anatomy, they're way too sick, there's some other covariable. A lot of it has to do with the anatomy. There's nowhere to intervene to. There's no bypassable target, there's nothing to open up with a balloon, etc. But we know that of this 85%, an additional 20% of patients don't benefit. So it really turns out that about 35% of patients who have this disease process shouldn't be getting. I mean, if you were the government or somebody saying we're the payer for this, then this happens in other countries. Quite frankly, in the UK, these patients don't get done, for example, right? That's not how we work in the US, that's for sure. So about 35%, and some of the papers say 40%, some say 25%, but roughly 35, or again, 1/3 of the patients probably should get something else. So can we save these limbs that do have critical limb ischemia? And Bill Marston and his group down at University of North Carolina has done a great job looking at this population, like the folks we can't get blood supply to. And we got a whole host of other things we kind of offer, but it's a hodgepodge, and it takes an incredible amount of dedication and a team that really is just focused on this. You can't use home nurses. You have to have them coming into a center once a week. They might be traveling from large distances. So there are some things that can be used. Hyperbaric oxygen is really only indicated. Probably a lot of people in the room have heard about it. There's a lot of lay press about it. But hyperbaric oxygen is really only indicated for diabetic foot ulcers, which is a different disease than critical limb ischemia. Some diabetic foot ulcers have critical limb ischemia, but not all of them. At least half of them don't. There's intermittent compression pumps which can work for this, not covered by insurance in the U.S. Some data, spinal cord stimulation, medications, gene therapy, stem cell therapy, and allogeneic cells that we'll be talking about. The issue here is the data is not great. And these are hard things because most of the time patients have to pay for this. These are hard things to say, you really got to pay for this because it's really going to help mom. That doesn't play too well in Pretoria. On the other hand, maybe a cure down here, cellular therapies. And I choose cure specifically because one of the things that's interesting about the potential for such therapy is you actually really would change the muscle, you change what's going on in there, and you could actually stop the progression of disease. When we do a stent, when we do an atherectomy, when we do a bypass, I'm going to give you an example. I've had one gentleman who's had 2 bypasses, and what's happening is his arteries distal to the bypass are continuing to harden. He smoked, he stopped smoking, he's on his lipid-lowering agent, he's on his antihypertensive, but the disease process is progressive. So his bypasses work till the artery that they're attached to closes off. Then we have to go back in and open that. And we keep doing that. But he's going to run out of artery before he runs out of life, unfortunately. So the idea here would be possibly actually curing it. And that's an idea we'd all like, right? We'd rather be cured than sort of just treated for a disease. I mean, if you could take a pill that cured hypertension and you never had to take anything again, that'd be a nice thing. So a cure, really? Well, I think a lot of you are familiar with the idea of gene therapy, and there have been numerous gene therapy trials, and this really started the idea of injectable things into tissue, and really started up in Boston. about 20, 25 years ago. One of the things that gene therapy trials haven't done well with is coming out to phase 3 trials. They really haven't worked. And in part, probably because gene therapy is a nice idea, but genes alone, they don't always transfect. They need a lot of other host factors. So they work in some people who have those, but we're not smart enough as humans to know which patient needs which. So you put them in, and they degrade, and they get inactivated very quickly, is my general thought about that. Well, what about cell therapy? Well, cell therapy is really interesting. And, taking a patient's own bone marrow or peripheral blood is nice, and injecting that into limb muscles is an interesting concept, and I've also been involved in some of those trials. And one of the things there, though, is, you wouldn't take a heart from an 84-year-old and say, gee, let's take another heart from an 84-year-old and transplant it into that patient, right? You take nice young cells, nice young heart. You wouldn't say take a kidney from a 92-year-old with diabetes and say, we're going to put that into the 24-year-old, right? You're going to take the young, healthy cells. So the problem here is you're taking cells usually from an older, sicker patient, a patient who has critical limb ischemia, who has other comorbidities, and then expecting those cells to be pluripotent. And none of these trials, one of these trials did try to do it, but none of these trials really, you don't really know what you're getting. You get the cells out, you kind of make them, maybe condense them a little bit and re-inject them. And it's very hard and cost containment-wise almost impossible to take these cells, send them somewhere, grow them, make sure they work, quantitate them, and bring them back. That's a nice idea, but and there was one trial that looked at doing that, and it just didn't enroll and closed. So what about autologous? So this is that idea. Taking allogeneic cells, they've shown that cells harvested from an older individual and those with cardiovascular risk, none of these cells have ever been taken out and really looked for functionality. Like, the concept works, and maybe for us in this room, if we broke a femur or we tore our Achilles tendon, taking our platelets and spinning them down might be an idea, but that doesn't work if you're 86 years old and you have diabetes. So again, not a great idea. These trials have been done and have had some interesting signals in their phase 2s. Their phase 3s have not played out well. So what about a potential solution? Well, what we're hearing about today is this idea of allogeneic cell therapy, where you're actually taking, and you're going to hear more about this obviously, but where you're actually taking real mesenchymal stem cells that are young and healthy from a single source and have been created into a pharmaceutical grade treatment where we know what we're giving, know how many cells, know the activity of the cells, and these cells are truly more potent. And then when they're injected, we have a sense that we're injecting a real pharmaceutical grade product. And we'll talk about the early phase studies here that have actually been dosing studies where you know how many cells you're giving. When I take blood or bone marrow out of a patient, spin it down in the operating room, and then re-inject it in the patient, I have no idea how many living cells I'm actually putting in there. So we kind of had to run through this. There's the idea of trying to treat the disease, which is long-term treatment, which is just kind of modifying what's going on and trying to get the patient to do better, but the disease progresses. There's the idea of the single biologic compound, which to date has not played out very well. Some very interesting early data, and really was kind of the start. VEGF obviously probably being the first injectable that really got an interest in this. Then there's the idea of a cocktail of a whole bunch of things, which probably in conjunction, I would say that if they're on cell therapy, patients are still going to be on a statin agent, they're still going to be on an antiplatelet agent, they're still going to need to have their hypertension treated. But if they could modify their lifestyle a lot, they might not need all those things. But this idea is a healthy donor, young cells, not limited in quantity, consistency also, and you know what you're actually doing. And in this case, immunoprivileged. These cells, you don't have to worry about them having an immunogenic response. So looking at the mechanism of action, over here on the right, a busy slide, and this is in your handout, I know, and available to you later, but fundamentally there's a whole bunch of things that go on here. But these mesenchymal stem cells, what they do is they actually will decrease and modulate the matrix metalloproteases, so an extracellular matrix can be formed, which is necessary for growth factors to work. Growth factors won't work without proteins to bind with, basically these extracellular matrices, collagen, et cetera. Those and the cells come together. They also reduce inflammation, and they modify the inflammatory response so that you can get neovascularization. One of the things that happens if you take a growth factor like VEGF and inject it into muscle, you get you actually get some new blood cells, and you get new capillaries, but they look like a little ball. I call them popcorn neovascularization. They don't go from point A to point B. They don't go anywhere. I just keep hitting this. Whoa, there we go. They just go in a circle. But if you put in a ECM, an extracellular matrix with that, they actually grow linearly. They actually go from point A to point B and carry oxygen from point A to point B. So you need all these things. So this is a way that we as humans, not being divine, I would have to say, can do something that we can kind of put in one shotgun approach, a cell that can do a whole bunch of things. As we see some of the other models that you're familiar with, or maybe there is a very classic model where you ligate the artery in the hind limb of a mouse, and then you can inject various things into it. Now it's a mouse model. But you look at day 0, and this is basically a color scan looking at the amount of perfusion in that tissue. These are 2 different mice. Day 0, you can see that this limb is completely ischemic. Once this is injected on that day, 21 days later, you can see that there's significant neovascularization in that. Let's see if these will play. Will it play? Good. Play without the... So the idea here is simply that you're going to see this is also the hind limb on the right-hand side, or on your right-hand side as you're facing this, with neovascularization in it, and the blood actually flowing through the vessels that have come back fundamentally after being injected here with the precursor allogeneic cells. So mechanism of action worked through the animal models, and to elucidate that, Phase 1 studies in critical limb ischemia in the U.S. and Germany. These are the small studies that show safety profile, and we'll talk about some of the almost positive safety benefits, if you will, momentarily. And the idea was a dose identification here. These studies get you the idea that there's a signal, it works, there's increased tissue perfusion, and we'll talk a little bit about it, but it's been determined that 2 treatments with 3 million cells apiece, 2 months apart, is a good dosing strategy. Most notably now is the next study, which has been finished, is the peripheral arterial disease. Now, critical limb ischemia is a subset of peripheral arterial disease. In general, as a researcher, we all know that looking at a severe disease, you're easier to see a big delta, a big change with a therapy. The more severe the disease is, the more likely a therapy is to have an effect, if it's going to have an effect. Arterial disease or claudication, the problem of having a blockage in an artery that when you walk reduces blood flow. So you feel fine when you're sitting there. You don't have critical limb ischemia, but when you try to walk down the street, you start to have not enough blood flow, not enough blood delivery to your leg. That peripheral arterial disease is a less severe subset of critical limb ischemia. So you'd expect it to be harder to prove a benefit in that type of disease. Well, looking at 172 patients, this phase 2 study in intermittent claudication shows that there's a real increase in maximal walking distance, a reduced number of surgeries, and also reduction actually their hemoglobin A1C, a marker of their diabetes, which more exercise is going to reduce that number, and also their CRP, which is an inflammatory marker, a general inflammatory marker that's actually associated with sudden cardiac death. So a bunch of things that go down. And it showed that the dosing, the 3 million cells, there were 2 different regimes, and I'll show those to you in a minute, but the dosing was the correct dosing. The 3 million cells, 2 months apart, was the best dosing. And then the current study that I'm involved in, this pivotal phase 3 study looking at critical limb ischemia in Europe and Israel, and we can present some early data. Of course, we don't know if they're getting the therapy or not, so it's still blinded data. So that's going to be very early data to present to you. So what happened in this PAD trial? Amputation-free survival at 6 months, the 100% in US and 93% in Germany for the active arm, or all active arm actually. And if you take a comparison to published data on no option CLI, these all look very good. And there's previous study data that we don't have to get into in detail, but looking at historic controls, a very favorable profile. Also taking a look at just their hemodynamic, and I know these are relatively small, but the improvement in the quality of life, which is a big deal to the FDA. The FDA wants to know that the therapy isn't only good, because of course, if I can save your life, but you hate your life the rest of it because your therapy was terrible. Example for some of you who may have been involved in any of the investments into endovascular aortic aneurysm repair. There was a study done, for example, in the UK after open aortic repair that said, even though you know this surgery saved your life, would you ever have this again? And in the UK, 2/3 of patients said, I would never have this again. And we even have to tell patients that now when we're doing an open repair. We say, you're not going to feel any better. You won't die of this disease, but you'll probably always feel a little worse than you do now, right? And people don't like that. So quality of life matters. That's true of a distal bypass. Some people, that could be cutting a person's leg from their groin to their ankle wide open. That can be a real issue. So quality of life was improved in both the U.S. and German arms. The reduction in pain was meaningful, and this was very meaningful with the 2 doses in both the U.S. And then actually they had improved perfusion, a measure of the oxygen in the tissue improved over the period of time, both in the U.S. and in the European group. So all these were very positive signals. This is looking at the dosing strategy. Okay, so the dosing strategy is over here that the, and this is the medium walking distance, so how far they could walk after treatment, right? So if you look at the group who got the 2 donor group, their walking distance increased dramatically. The placebo group was down here, and the lower dose was over here. So again, best donor group was idealized, and it was clear that that was going to be the best group for everybody to do well with. This just takes a look at if the patients went on to have anything bad happen to them and what were the best dosing. And again, this 3 million units dosed from 2 donors to make sure that everything was most homogeneous, and dosed 2 months apart was the best dosing. So that's the dosing we're moving forward to. So this is a standard dosing trial. And then I said there's actually a favorable safety profile. If you just compare the group who got the 3 million 2 times apart and per the placebo from the PAD study, this claudication study, major amputations were less. Now, these aren't necessarily statistically different, but these are things you worry about. Malignancies were less, which is something that in all growth factor studies you should be thinking of. From a market share down the road, that can be a bad thing, so you want to keep seeing that there's at least no positive effect on increasing malignancy. And here there's actually a reduction. I wouldn't say that it reduces anything, but it's certainly not an increase. Infections are equal, which you'd probably expect. Other peripheral vascular disorders, again, fairly equal. Cardiac disorders, if anything, go down. And some of these trials, in this trial, the critical limb ischemia trial, may show, this can happen. You could actually have somewhat decreased cardiac mortality. Renal disorders were diminished, and actually eye problems. And remember, a lot of these people have proliferative retinopathy, so actually having reduction in eye problems is also something you don't want to see the increase. So these were all at least flatline or decreases. So the study is we're talking about now, critical limb ischemia with minor tissue loss, unsuitable for revascularization. So the only patients we're not really including that have critical limb ischemia are the patients who I'm pretty sure I'm going to have to amputate this week. Can't get in this study. This has to be someone who's aiming towards possible amputation. This also is a patient who actually already has a little bit of gangrene or an ulcer. Sample size, 246 patients. The 3 million cells, as we discussed, versus the placebo. It's a randomization of 2 to 1. It's IM injections in the affected leg, 2 treatments, 8 weeks apart. It already has been determined to be the best dosing. And their composite efficacy endpoint: reduction in pain, complete wound healing, quality of life, taking a look at their amputations, increase in TCPO2, and their cytokine levels. So these are early stage results. Now, we don't know if the patient's getting active agent or not. I mean, this is completely blinded. But it's rare that these patients spontaneously get better. I'll leave it at that. So this is a patient who has a heel ulcer, a difficult thing to treat, and has undergone appropriate treatment, full wound closure. A patient with a toe ulcer, again, usually would result in a toe amputation, 96% area reduction. Obviously, the tip of a toe is a difficult thing to get your imaging around. Another heel ulcer, black eschar, kind of classic for this type of disease process, down to about 95% area reduction after 8 weeks. And a plantar foot ulcer, where this patient, I can guarantee you, is also diabetic, as well as having, because their foot is malformed, as well as having arterial disease. And you can see 54% area reduction after 8 weeks. So, positive results in the trial. Again, I don't know what they're getting. Maybe the placebo is fantastic, but that's not what I think, but anyway. That's an opinion. So where's the need? Well, right now, where do we have need? I've already alluded, and I didn't show you this in the PREVENT data, but in the PREVENT data, within the first month, about 20% of patients who have a bypass, their bypass fails. And you kind of know it's going to, because probably they were some of the patients who shouldn't have gotten a bypass in the first place. But in those patients, we would like to be able to have something where we could adjunct that. We could give the patient therapy as soon as we know something's not doing well. Or they have a bypass, but it's not giving enough blood flow to the part of the foot that we need to heal. Maybe we could have something that we could adjunct that and speed that along. So, and that, in this case, an injectable adjunct might be the ideal thing. 2 weeks after failed percutaneous intervention, again, we've angioplasty, we'd open up, and this doesn't mean even the procedure didn't work, but again, maybe we just couldn't get blood to the foot that we needed to. We could get it to the knee, but we can't get it to the foot. So an adjunct there. Patients without target vessels in the foot, you do your angiogram right off the bat, you say, there's nothing I can get to your foot, there's nothing I can do. And that's sort of in that 15% that we already know about. And then there's patients who might have good anatomy, but they're not really ambulatory, they're in a wheelchair, their family doesn't want them to be amputated, they don't want to be amputated, but we know they're really not medically going to be a good candidate for any of these procedures. They might not have no target vessels, but there's a good chance they do. But again, they just probably really shouldn't undergo a major procedure. This is another area where having something other than bypass to offer these patients would be a real benefit to us. So the current trial doesn't look at all these folks. The current trial looks at a very select subset. But point is that the group that we would then use this on, if this really gave us a positive therapy, I think would grow significantly up to about 33-34% of the patients that we're currently treating, potentially, because we'd use it as an adjunct, and we'd also have a third treatment option instead of just the open bypass endovascular intervention. And I think that's it for me. Thank you very much for your attention.
I'd like to invite Mary Yost from the SAGE group.
Thank you. Okay, I'm going to talk about PAD and CLI, the prevalence, the economic cost, and the market opportunity. First, we're going to start with PAD. If you look at the current U.S. prevalence of major chronic diseases, you see that at almost 20 million, PAD exceeds coronary heart disease, all cancers put together, stroke, etc. The only more common prevalent chronic disease is diabetes at almost 36 million. Yet, PAD is the ignored cardiovascular disease. It's underestimated, underdiagnosed, and undertreated, and this increases morbidity, mortality, and costs. If you look at the most commonly quoted estimate for PAD in the U.S., it's 8 to 12 million in the red circle. The Crickey Partners estimates. That was a very good estimate for the U.S. population circa 1995. However, since in the last 20 years, diabetes has exploded and the population has aged considerably. And these are two key risk factors for PAD. If you take the percent prevalence in the Crickey study, apply it to the U.S. population in 2015, you get a range of 11 to 18 million. Likewise, if you take the Neelerin group percent prevalence of PAD in the population ages 40 and over, you get 18 million. And those two 18 million numbers are in line with the diabetes estimate, that's ours, of 20 million. Age and diabetes are significant risk factors for PAD. PAD prevalence increases with age. In those 40 to 59, about 3% have PAD. In those 70 and older, it's 19%. These numbers vary by the studies, of course, but it increases significantly with age. Also, if you look at diabetes, there's a unique relationship with diabetes. If you look at the population ages 50 and older, if you look at those with normal glucose, 10 to 20% have PAD. But if you look at diabetics, 30 to 40% will have PAD. Looking at the U.S. PAD prevalence over time, and this is the diabetes method, 11.3 million in 1995, 19.8 million in 2015, and increasing to 24.5 million by 2030. That is based on aging of the population only. It's holding diabetes prevalence constant at the most recently reported percents. Now, if diabetes continues to increase as it has in the last 20 years, that 2030 number will be conservative. Likewise, as in the U.S., globally, aging and diabetes are driving the growth of PAD. If you look at the world population ages 60 and over on the left, look at that blue box, you see that between 2000 and 2050, there's a huge increase. Just look at the top numbers. There's a huge increase in the population ages 60 and over. In addition, the IDF has estimated that diabetes will increase by 55% in 2035. So looking at worldwide estimates for PAD, we really don't have hardly any. Fowkes and Group recently estimated that 202 million people worldwide had PAD in 2010, and that was up 24% from the number in 2000. Now, if you compare those with the numbers by the diabetes method, and there are 7 countries and regions here, if you look at the total in the bottom, 163 to 194 million. So how does that compare to the 200 million? The population in these 7 countries and regions is only a little bit more than 50% of the world population. So if you do a simplistic calculation, it indicates that that 200 million is very conservative. It's probably 300 million plus. Even though PAD is ignored, it turns out it's the most prevalent worldwide cardiovascular disease. Roth and Group estimated that cardiovascular diseases were 423 million in 2015. PAD at 155 million, this is their estimate, was higher than the 111 million with ischemic heart disease and dominated cerebrovascular disease at 42 million. So even with these conservative numbers, it is widely prevalent but continues to be underestimated. So turning now to the cost, we're going to focus on the U.S. If you look at the annual economic burden of PAD, it's between 200 and 400 billion. The lower number represents the per patient costs in the U.S. REACH registry. The higher number is the per patient costs in the Margolis managed care study. Both of these studies looked at the same type of costs, inpatient and outpatient costs. The key difference between the two numbers is that REACH registry looked at cardiovascular costs only, whereas the Margolis study looked at all-cause costs. It turns out that hospital costs represent the majority of PAD costs, or between 65 and almost 90% of the costs are hospital, or calculating 147 billion in REACH, 363 billion in the managed care study. By way of comparison, 1/3 of U.S. healthcare expenditures are hospital. So PAD is treated very heavily inpatient versus other diseases. It also turns out that non-PAD costs are significant. If you look at cardiovascular hospitalizations, cardiovascular costs represent 43% of those costs. But if you look at all-cause hospitalizations, non-PAD represents 90% of the costs, again indicating the high prevalence of comorbid conditions. So who pays the bill? Medicare and Medicaid pay 80% of the bill. In other words, for you Americans, your tax dollars. So if we look at Medicare patients, PAD and Medicare is between 10 and 21% of Medicare patients are treated for PAD at a cost of between $22,000 and over $72,000. That's a huge range. It reflects the different definitions of PAD and the types of treatments included. In particular, long-term care is included in that higher number, which is why I tend to use that number. Significantly, above-the-knee amputation is the 3rd most commonly performed procedure in Medicare patients with PAD. So if we look at the $72,000 plus spent on the Medicare PAD patients, that's over 6 times higher than the $11,000 plus spent on the average beneficiary. So then, finalizing, looking at the economic burden of PAD, 200 and 400 billion, compared with diabetes, and these are direct costs only, 176 billion with diabetes, higher than CAD, and all cancers put together cost $88 billion. So PAD is a very expensive disease to us taxpayers. Turning now to CLI, which is the most severe and deadly form of the disease. It turns out that amputation and mortality increase with disease severity. As you can see here, data from a recent German study showed that Rutherford category 1 to 3, those are IC patients, at 4 years, a little less than 5% underwent amputation. Rutherford 4 rest pain, about 12% underwent amputation. By the time they had gangrene, over 67% of those patients underwent an amputation. Similar trends with mortality rates. 19% died in Rutherford 1 to 3 IC patients, increasing to 38% in rest pain. Again, by the time that patient was in the gangrene, or by the time the patient was gangrene, then almost 64% were dead at 4 years. This German data, the US data, shows the same type of trends. If we look at prevalence of CLI in the US, we estimate between 2 and 3.4 million. Now that's prevalence. Only a fraction of these patients are actually diagnosed and treated. 700 to 800,000, we estimate, are treated with either revascularization or amputation. We look at prevalence over time. We estimate 3.4 million currently, increasing to 4.7 million by 2030. Again, holding diabetes constant, aging only. So that could be a conservative number. If we look for global CLI estimates, well, there aren't any. Not that I am aware of that have been published. But you can get an initial estimate by looking at the Fowlkson group, 200 plus million. Neeler and group found that CLI was 11% of PAD. In our work, it's 15%. So if you simply do the math, CLI globally, 22 to 30 million. So again, how does that compare with the specific estimates that we've made? And the same 7 countries and regions that we saw before, which we have made the specific estimates for. The total 20 to 23 million. Again, thinking back to the 22 to 30 million, these populations represent only a little bit more than 50% of the world population. So that suggests that 20 to 30 million is a very conservative number. I might also point out, if you look at China and India, are clearly the leaders, but not a good thing to be, in critical limb ischemia, followed by Western Europe and the United States. Excuse me. Treatment costs increase with disease severity. As you can see here, these are Medicare patients with CLI, and this study looked at 4-year inpatient and outpatient treatment costs. Thank you. Looked at 4-year inpatient and outpatient treatment costs, and this was during the follow-up. So Rutherford category 4 patients with rest pain cost the system over $78,000. Rutherford 5 ulcers cost over $91,000, and Rutherford 6 cost over $116,000. Major amputation, it turns out, is frequently the first and the only therapy for CLI. We estimate the result is 65 to 80,000 major amputations performed annually at a direct cost of $11+ billion. That's just inpatient and outpatient costs. The real cost is probably closer to $70 billion, and that's when you add in the lifetime costs and the unreimbursed patient costs. It's a very expensive treatment for these patients. So if we look at interventional costs for CLI, and interventions are endovascular bypass and major amputation, we've only recently, like within the last couple years, had any published data on interventional costs. In general, the cost and economic data on PAD and CLI is almost non-existent. You see here on the top, we're looking at inpatient costs, and inpatient costs for different combinations. For example, endovascular bypass in one study was about $25,000. 2 other studies showed a range of $31,000 to $33,000 for different combinations of endovascular bypass and major amputation. Mustafa and group recently published, again, the data on CLI patients in Medicare, and they looked at inpatient and outpatient costs. And what they found was that bypass cost $49,000 plus, endovascular a little bit more, major amputation cost close to $56,000. Now, two of the authors took their cost data from their studies, used incidence, I believe, and estimated that CLI costs between $4 and $12 billion. That's a very, very conservative number. So turning now to CLI, it's a large market already, and there's also significant potential. If we look at the CLI market, we start with the 3.4 million CLI patients. However, 40 to 50% of this disease is bilateral. So in terms of limbs for interventional treatments, you need to look, in terms of interventional treatments, you need to look at limbs. So we estimate about 5 million critically ischemic limbs. However, only about 1 million of these, we estimate, are actually treated. And treatments here are revascularization, that's bypass and endovascular, amputation, and palliative/wound care. And the revasc is in the blue, major amputation is in the rust, and gold is the palliative/wound care. As you can see in the smaller column, the actual market is considerably smaller in each of these categories. For example, in revascularization, we estimate between 500 and 600,000 limbs are actually treated currently, but the potential is about 2.8 million. Now, you say, well, what's happening to all these patients? Basically, they're dying, and they're also not being coded correctly. They're just not getting in the system. We can go into that later if people want. If we look at the interventional market currently, we estimate it exceeds $23.5 billion, and this is in limbs, treating category 4 to 6 patients. And we assumed a $31,400 cost from the, I believe it's the Colte study. And this is bypass, endovascular, and major amputation, just taking the average. Finally, the question is, what kind of potential opportunity is there for an alternative therapy, some alternative to interventional, to major amputation in particular, and to the palliative and wound care segments? We estimate between 4 and 9 billion, and that's based on treatment with treatment in Rutherford 4 and 5 patients. The lower figure is a simple calculation. We did about 10 different calculations, by the way. The lower figure is a simple calculation that just says, let's assume 20% of the limbs in Rutherford 4 and 5 could be treated with a cell therapy product. And that product is priced at around $35,000. The higher figure is a much more complicated estimate, and that starts with the limbs by Rutherford 4 and 5, assumptions regarding the treatments, revascularization, amputation, and palliative wound care, and then assumptions in each of those treatment categories in terms of what percentage penetration a cell therapy could make. Now, I emphasize all of this assumes, you have to assume two very key things. First, that safety and efficacy continues to be favorable. If it's not, then you can forget about these estimates. And secondly, that the FDA and other regulatory bodies will approve these therapies, of course. And this is the overall market opportunity. It does not go into market shares for one company or another. It's just like, this is my current thought on it. So, conclusions. PAD is highly prevalent and commonly underestimated. The macroeconomic cost is high, between 200 and 400 billion. Hospital costs account for the majority of the total PAD costs. Hospital costs are significantly increased by cardiovascular and non-PAD events. And the 2015 economic burden of PAD exceeds that of diabetes, CAD, and all cancers combined. More conclusions. CLI in the U.S. is estimated between 2 and 3.4 million. Mortality and amputation increase with disease severity. Costs increase with disease severity, which suggests that earlier diagnosis and treatment is likely to reduce the costs. And the CLI per patient costs for interventional therapy are quite high, inpatient costs ranging between $31,000 and $33,000, inpatient plus outpatient costs $49,000 to $56,000, and that the market opportunity for cell therapies is estimated at $4 to $9 billion, again, assuming safety and efficacy remain favorable. So that concludes my presentation. Thank you.
Thank you very much, Mary.
Yeah, I'm really from California.
And with that, I would like to move to my presentation. I do like to remind to our webcast guests that they can ask questions. It's a question at lifesci.com. So, Pluristem. We were hearing Professor Lantis and Mary Yost talking about how it looks in clinical setting and how the market looks like. And I'd like to spend the next slides talking what Pluristem is doing in this industry and how we are seeing the markets, time to markets, etc. As a reminder, everything that we are doing is Pluristem. We are collecting cells from placenta after full-term delivery. We expand the cells in technology, the bioreactor technology that we developed in the last 12 years. And eventually we're ending up with an off-the-shelf product. I don't know if any of you ever saw the product, but it looks like that. The vial that I hold in my hand contains about 100 million placenta cells. So when Dr. Lantis and his team wants to do a treatment, they actually have to do nothing, just thaw the cells and do a simple IM administration. Not nothing complicated, but the good one. So it makes it more available for every clinical team across the globe to administer the cells into the muscle. The way that the cells are functioning is by endocrine and paracrine effect, meaning we inject the cells into the patient body, the cells are starting to interact with the patient body, as cells do. They receive signals from the patient body, and they are responding by secreting cocktails of proteins, cocktail of biologics. So our product is actually an agent, a smart agent, that interact, communicate with the body, and is able to respond by secreting an adaptive cocktail of proteins that are pushing the body towards regeneration. And this is what we do. Pluristem is one of the leading regenerative medicine companies in the world, and that's the key. Looking at the healthcare spending globally, that's the key to reduce the healthcare spending by providing regenerative agents to our patients. We are starting with a very good starting point, the placenta. The placenta is a young, fresh, this is actually the youngest available adult cells that we can get. We're getting the cells after full-term delivery, placenta from full-term delivery. These are very young, very fresh, very potent cells in very high quality, in very high quantities. Placenta is also a very unique organ from immunological point of view. I bring you back to pregnancy. Pregnancy is the only unique situation in nature that we are familiar with, that you have two immune systems living together, the mother and the baby. And there is no immune response of the one against the other. And if we think about it, a mother can be even a surrogate mother. She can carry someone else's child. But still, they're not going to be immune response of the mother against the baby or vice versa. And that's our starting growth material, which allows us to make a real off-the-shelf product. And from one placenta, we can treat over 20,000 people. We can treat 20,000 people because we are doubling the cells using our technology. For many years, Pluristem was the first company that was very active in placenta, and we were seeing the potential of it. I'm very pleased that recently, we're seeing also the NIH recently declared that that's going to be the decade of the placenta research. So people understand that the placenta, it's a very potent organ that's actually the source of life, and we're using this source of life to bring these young, fresh cells into an elderly population and to create the regeneration effect. I said that it's a good starting point because it's not enough. Cells, in order to expand cells in a commercial way, and I welcome all of you to visit us in our facility, it looks like a full-blown industrial biological manufacturing facility. It's not a lab. It's not a small place. We are expanding cells in these reactors, trillions of cells. All of them, of course, it's a cGMP facility, the highest quality in the world. All the cells have a perfect batch-to-batch consistency. All the regulators, the FDA, the European, the Japanese, the Korean, the Israelis, all of them consent on this process. We were able to show that each vial that leaves Pluristem facility have the same exact number of cells that will do the same exact thing. And that's the way that we are looking at it. Cellular therapy, it's actually a development or evolution of biologics. It's not a breakthrough or it's not a revolution, it's an evolution of biologics. Bringing the cells that can interact, respond, but it has to be in the same standard that we are used to see in the biotechnology industry. Pluristem invested heavily into these technologies, and we are holding really the capacity or the capabilities to serve millions of patients. We can serve millions of patients all over the world with our manufacturing capabilities, and that's the way that we are seeing building a biotechnology company. From day one, we decided that Pluristem is going to be a full vertical company. And you can see around in our industry, or in cellular therapy and regenerative medicine, we are probably the only player, or one of the very few players, that holds the entire capabilities. We are developing the technology, we're having manufacturing, QC, QA, logistics, clinical development, regulation, until the patient bed. So we have a very wide perspective of understanding how the market looks like, and that gives us a very unique position to understand what you need to do on the manufacturing floor, but also what the FDA wants, and what the medical team needs. So that's the way that we are able to build a product that will be really beneficial for these patients and for the physicians, which are our partners in using this technology. Today, by using the technology, the bioreactor, and understand that we need to fully control the manufacturing process, Pluristem is a platform of products. Two of them, the PLX-PAD and the PLX-R18, are in advanced clinical development. The new guy in the neighborhood, the PLX Immune, that we are currently developing for anti-cancer treatment. But as you can see, each of the products is applicable for more than one indication. The most advanced program, the lead product in PLX-PAD, we are using for CLI and muscle regeneration. The PLX-R18 for hematological disorders, and PLX Immune, that's the new product that we're using for anti-cancer development. We are able to manufacture so many different products only because we are controlling the manufacturing. We are able to control each and every parameter in the expansion process, and that's what makes it so unique. We are holding a very robust, advanced pipeline, especially compared to company our size. The phase 3 studies that we discussed today, we already initiated the studies several months ago, enrolling patients very nicely. It's a small study, 246 patients, that we're going to go through the regulatory designation in a minute. We completed the phase 2 data that Dr. Lantis presented. We're having additional program that already launched a couple of months ago with a muscle regeneration after a hip fracture. We are targeting the soft tissue regeneration. We do not target the bone. We do not target the implants. But these cells, as proven in a lot of studies, we're not going to review it today, but you can find it in our website. We are shown that injecting these cells, we are actually able to regenerate the muscle following a trauma, like a massive surgery, a stronger muscle force, a higher muscle volume. And the acute radiation syndrome, which is our lead hematological project that we are doing with the PLX-R18. This is studies that are done, conducted, and funded by the US government through the NIH as well as the DoD. As you can see, all of the studies, the phase 3 studies, the advanced studies are funded by third parties. We were fortunate enough to capture non-diluting funding from government, regulators, and the customers that are actually paying for the development. That allows us to move in parallel in such a robust pipeline. And we have an earlier phase studies that we're not going to discuss today. The lead indication that we discussed today, I think that Mary presented the unbelievable numbers that, especially here in the US, that we are looking at. But you should understand that, and we're going to see the timelines. We are targeting an indication which is a multi-billion-dollar indication. In the next few years, we are targeting, according to our estimation, more than $2 billion in potential revenues to Pluristem. As you saw, the numbers can be potentially much higher, but this is a very large indication with significant unmet need. We are very confident with what we're able to demonstrate till now, and potentially our regenerative medicine products is a solution for the CLI patient, and we are seeing a very nice increase or potentially very nice revenue ramp up for this product. The assumptions that you see here are much more conservative than the estimations that are available, but nevertheless, we're seeing a substantial market that Pluristem is looking at. And a very good example for that happened just recently. We understand the need. We hear the patients, we hear the physicians. But the FDA recently also said, in parallel to the phase 3 study that we are running, we can start to treat patients in real-world data. We filed and approved an expanded access program. It basically says that patients that are not eligible to be included in the protocol, in the clinical protocol for many reasons, the inclusion-exclusion, they actually can be treated under the expanded access program. Recently, the FDA also approved a cost reimbursement for this product. We did engage with a third party here in the US that is going to launch and conduct all this expanded access program. So we're launching, we are doing the phase 3 studies, but we're going to treat patients here in the US with a full cost reimbursement now. It means that there is, the way that I see it, we see the confidence of the FDA, first of all, in the safety, in the efficacy, but the significant unmet need of this product. Because if 40% of this patient will die or amputate in 1 year, that's a significant unmet need. And if the therapy is available, we're very pleased that we received this designation from the FDA. And something is happening. All of us should know that. We are sitting in this room happily, but we are aging, all of us. And the world is aging. Actually, the numbers are unbelievable. We are seeing the trends, and I'm looking at the trends also, especially in the Asian markets, in Europe, but also here in the US. And I think that the fact that we're seeing the aging, it translates immediately to significant increase in healthcare spending. All of you are US taxpayers, so about 90% of your GDP goes to healthcare spending. It increased by almost 0.5% each and every year. And by understanding that, it eventually leads, in the last 2 years or so, or 2.5 years, the main regulators, it started in Japan, moved to Europe, US, but now we're seeing also China, we're seeing Korea and other territories. Basically, all of them are saying, we need something else. We need advanced technologies. We need regenerative medicine technologies. We are working closely with all of these regulators. And I think that today we have a commissioner who's the FDA, Scott Gottlieb, that say very clearly, this is a strategic for the US. We need to develop regenerative medicine technologies. And I'm very confident that Pluristem will be the leading company in providing this solution for regenerative medicine technologies. We need to reduce significantly the chronic treatment, the endless number of hospitalization days, and to provide with some new solution. We are fortunate enough that all of these main regulators are allowing us to move quickly. This is part of the regulatory pathway that Pluristem earned in the last 2 years. In Europe, in Japan, and here in the US, for all of our clinical studies. As you saw from our pipeline, it's relatively small studies that we are able to move quickly into the markets. And in most of the cases, the governments are also providing us with funding that tells me that there is a significant unmet need and significant interest in our product. So that's a unique regulatory environment. It's not going to stay forever, but I see a very interesting 3 to 4 years, and our goal in Pluristem is to push as many products as we can to the market. And this is exactly what we are doing. We developed a lot of technologies in the last 12 years. While we are holding our main assets, we're holding our therapeutic assets. In the last few months, if you were following the company, we did enter into a process that we are bringing partnering agreement to some of the technologies that we developed. Last week, we announced signing an agreement with Chart Industries for a thawing device that we developed. We developed this device for our own use. So when the medical team have to thaw the cells, they don't have to use a water bath. So it's a full automated thawing device. The guys in Chart that we work closely with them told me, okay, it's a beautiful device. We can sell it for not only for you, let us sell it. We said, fine. We got into a licensing agreement. They're going to start to market the product. We're going to get revenues. That's going to bring cash to Pluristem in 2019. Same thing we announced with Thermo Fisher a couple of months ago. Thermo Fisher, one of the largest companies in our industry. Their management see regenerative medicine as strategic. And if they see that as a strategic, I totally agree with them. And they're probably going to have the capabilities to make it strategic industry. We're going to develop with Thermo Fisher a series of products from serum-free media to cytokines to other devices that actually will enable this industry to move from R&D grade to industrial grade. And their CEO told me, you are the most technological player in the industry. And as Thermo, we have the capabilities, but you are seeing everything from manufacturing to the patient bed. And that's a unique combination between a giant that have all the capacity to develop that to Pluristem to understand the need, the really need, how it needs to look like, and how it looks in industrial scales. So you're going to see more of that coming. For example, these two products will inject cash to company in 2019. The expanded access will provide us also additional information, but potentially additional revenues. And we are targeting ourselves as we are getting closer and closer to marketing. So this is what's going to happen. And I mentioned the CLI. We're having the expanded access program. It's all fast-tracked, and we have an adaptive pathways in Europe. All of that allows us to move quickly into the market. In the PAD and CLI, we are enrolling very nicely. We have here with us Dan Perez, our VP clinical. He works hard to enroll the patients in the timeline that we did find. We expect to complete enrollment for the European readout, and afterwards to the US readout. So we expect to have end of enrollment for half of the population, H1 19. So the data will be at H1 20. At H1 20, we will complete enrollment of the entire study with a full readout in H1 for 2021 for the CLI study in the US. But very importantly, next year and the year after that, and actually on each and every period, we will be able to provide real-world data in the expanded access. The expanded access provides us the ability to indicate to you, the one that are watching the company, our shareholders, to understand how the real-world data looks like. And from what I've seen so far, I have a very reasonable way to assume that real-world data probably is going to look always much better than in clinical studies because they have no good therapy, these patients. So we're going to provide the real-world data. We're going to generate revenues as long as we are moving forward with the enrollment of the study and providing the full data set for approval. But as I mentioned, Pluristem, it's not a single product or a single project company. These are the additional milestones that are coming from other products, which are not PAD or CLI. We do expect to get a contract from the US government next year in 2019 for the acute radiation syndrome. We do expect to have a data readout from these pivotal studies that are developed under the animal rule of the FDA. And we do expect to have the BLA for the muscle regeneration following hip fracture during that period. So the next 2 years are extremely busy for us. We are enrolling patients. It looks good. I think that the company was never in a better position than it is now. We have a lot of data sets, a lot of data readouts. As I mentioned, we are focusing in injecting cash to the company in 2019. Just to give you a sense, in the last 3 years or 3 to 4 years, we were able to capture over $80 million in non-diluting funding. It came from Europe, it came from the US, it came from Israel, it came from different partners. So it tells me that there is a keen interest. We are fortunate enough that we don't have to give any rights in these assets. We're keeping the assets, but we are getting our partners supporting us to move forward quickly into the markets. And for me, it's all a good sign. And by that, I would like to thank you and to open it for questions.
Thank you all. That was a very nice presentation. Just a couple of questions. One is, do you have an idea of what you're going to charge and what is going to be allowed for these injections by the Medicare or whoever governmental insurance companies?
Thank you for the question. Yes, so we are doing an intensive market research with payers, especially here in the US, but also in Europe. And we are building our estimation. We do believe that we can charge the product in the range of $25,000 to $35,000 US. saving still half of the cost for the healthcare system, but allowing us also to become very profitable in these numbers.
I just have a follow-up. Have you ever considered injecting patients who have had strokes where they're neurologically compromised, they get muscle atrophy, and then you then inject the muscle to see whether or not, independent of neural stimulation, you can regenerate muscle? That could be a very big market for you.
You are absolutely right. I'll tell you as follows. On a weekly basis, really, literally on a weekly basis, we get a lot of different physicians, doctor calling to do physician-initiated studies. The indication that you mentioned is probably a top priority. Muscle wasting in general, or cachexia, is a big indication, especially after a traumatic event. It can be either stroke or cardiac event that the patient is non-functional. We have to be very focused in the product that we are bringing to market, so we cannot overexpand in our studies. But it's a definitely very interesting indication. We have nice supporting data that their potential it can be beneficial, and I don't see that happening in the next 2 years before we are launching the product, but it's definitely in our mid-term pipeline.
That was a great presentation by both Dr. Lantis and Ms. Yost. Just a couple of quick questions. One is a high-level question. Is basically with such a high prevalence of PAD, what keeps both the industry and the clinicians trying to identify modalities, therapies that can help these patients?
I'm sorry, I don't quite understand. What keeps us trying to find them, or what?
What's the pushback, or what are the issues that makes it difficult to come up with something?
Well, one is that I'm not sure that. Well, one's the disease process, right? So probably the rudimentary thoughts that we have in the world of treating this disease are lag behind the multimodality therapies that are available for cancer. But most diseases probably deserve that type of approach. So the thing is that you get into, okay, I did a bypass. Circulation's better. Well, there's a little bit of, who manages the arterial disease afterwards? Does it get managed? How these patients do? And most patients who have cancer surgery, for example, and they get their chemotherapy and they get their radiation therapy and they complete their course. But they also complete their course, right? They get done. No, not in all cases. Some cases might be on suppression therapy. But they make those follow-ups. On the other hand, it's very common that the adjunctive therapies, such as taking a statin, taking an antiplatelet agent, which all have been shown to benefit these patients, they stop. A year later, stop taking the medications. So a lot of the problem is that this is a long-term, chronic, ongoing disease, and these episodic events, and that's why I alluded to possibly a cure, right? These episodic events, it's hard for the human just to continue to take that therapy and do all their follow-up forever. So I think it has a little bit more to do with the human condition than, absolute roadblocks.
Okay. A couple of specific questions just on the phase 3 trial itself. For this particular patient population, what would you recommend if PLX-PAD was not there, or in general, what do you normally prescribe for these folks?
So if you take the population that has the non-reconstructive, the very specific ones, a lot of these patients do end up with an above-knee amputation, as Mary alluded to, or they end up with palliative care, potentially, depending on the family's wishes. I just had 2 patients this week who those were their options. And they were both beyond this population of the study because they're actually they need one or the other. They're imminently need an amputation. And then the other group, though, specifically for this population, is probably at the moment, I recommend arterial counterpulsation therapy, the arterial pump that works for an hour and 15 minutes twice a day. You have to be home. You have to put this thing on. Your family has to pay for it. Someone has to put it on the leg. Most nursing homes won't do it. But that's probably our next best option at the moment.
And my last question, for this particular trial, what would you say is clinically meaningful in terms of results that we could see, which will make you recommend this therapy against what's out there? Thank you.
Yeah, no, you're very welcome. I think you see a 20% reduction in amputation, and it's a composite endpoint, though, right? So basically, people have increased quality of life, they have fewer amputations, and they probably have a couple other things that occur, increased, and this is actually this study's going to look at wound healing as well, which is unique. Most interventional studies, just trying to say, I do a bypass, and what's the healing rate afterwards? That's almost never been studied. And limb salvages, but not the healing rate. So if we see increased, it's going to be a composite, right? But it's sort of increased healing, equal or better quality of life with decreased amputations. And I think, that signal in total, you probably just need about a 20% improvement to make it significant. Now, it might be greater than that. But.
It's Matt Kaplan from Ladenburg. Just to follow up on that question and dig in a little bit more deeply, obviously, from all the data that was presented, the unmet need here is tremendous. The market size is large. But thinking about the phase 3 design, the endpoint is a time to endpoint, not number of. Mm-hmm. So if you think about the typical length of the time to an event in this patient population and the magnitude of effect that you're thinking about that you'll be able to tease out here, help us understand it in that context in terms of what is clinically meaningful in a time to.
Yeah. So and you're right. And the secondary endpoints are, of course, are absolute percentage and numbers, of course. Primary endpoint's different. But the time to effect, so these patients, if you look at the early numbers we presented, were, that 15 to 25% amputation rate is thought to occur within a 6-month time frame. And the time to here is looked at over a 1-year time frame. So you should be able to capture some of those. Now, we also showed you maybe treatment, maybe not treatment, but wounds that healed, that we wouldn't expect to heal. Usually these wounds are completely stagnant. So in that case, that's a very big signal. You actually go from a number that's 0, or actually going down, or however you want to look at it, but moving in a negative direction, to a number that theoretically would be moving in the positive direction. So if they're actually healing over 8 weeks, which is what you're seeing here, that's a very strong signal that you're moving at opposite directions. And that's not typical of how these patients do. So if the placebo has no effect, we'll just assume it has no effect, and the treatment has an effect, you're going to actually get that time differential, especially on the wound healing component. You're going to see in a real time, within 2 to 3 months, and have a real sense that something's changing dramatically.
So the delta that you're looking for is a 1-month delta, a 2-month delta between the two groups, or a 6-month delta?
If you're talking about the statistical versus the statistical design versus the mental design, within the mental design of what you're actually going to see something. I'd say it's for the clinician to mean something. The clinician says, "Gee, this really means something." Probably a 2-month delta.
Okay, thank you. And then in terms of some of the other studies that we've seen in terms of wound healing in the diabetic foot ulcer space, typically none of those trials have worked, because when you actually enroll in a study, you're receiving better care. How do you think this study can differ from those other studies?
Well, the interesting portion, very good question, but to be clear, this study is critical limb ischemia, which is a different beast than the diabetic foot ulcer. So the diabetic foot ulcer trials all require patients who have adequate perfusion. They have adequate circulation. And so they're very dependent upon offloading and lifestyle modification as well. And as you said, they get, a lot of times, these controlled arms, everybody gets better care, and they do well. Or they don't have very good offloading in either arm, so neither does well. But this really is a therapy that theoretically is pretty much independent of other good practices, because at the moment, good clinical practice for the group who doesn't have arterial circulation. One isn't published, doesn't really exist, and we don't even know what to do for these folks. So they tend to worsen, right, no matter what. And there's not really an intervention. So the control arm here is going to be much more dependent upon actual revascularization. To be more, dramatic about it, certainly, a gentleman who did a bypass on last week, he went from having a terrible-looking forefoot to a completely pink granular foot. So when you get real perfusion, there's a huge difference in how these patients behave. And I'm not sure this will work quite like that, but to your question, the control arm has much less ability to do well because they're just in a study. They're just going to be seen a lot, but there's nothing we can do to make them better.
Thanks a lot.
Sure.
Hi, thanks everyone. George Zavoyko from B. Riley FBR. Dr. Lantis, I assume the study you were referring to before was the Astrum study that couldn't enroll patients. And I think part of the problem that they had was that they had a very narrow eligibility criteria, and they required several days, if not weeks, of central review to make sure that the patient actually was eligible. Did you participate in that study?
Yes.
Yeah. So what have you learned from that study that you're applying to this study so that some of those same mistakes aren't repeated?
Yeah, just to be clear to everybody, the study also was a study that had cells that you would send out and they would be actually quantified and grown and come back. There was also that delay. There was a real delay in therapy.
Right, yeah.
So the huge difference right there is there was basically a month delay from harvest to treatment. And that was too long a delay built in. And that's very different here because we have an off-the-shelf, So we have the run-in phase is much shorter here. Some of the things are mandated. You still need to have a retinal exam. You need to have a couple other things. You don't need to have quite the cancer screening. Actually, this population, because of their age, you're meant to follow the appropriate guidelines, but an 83-year-old woman's not meant to be getting a mammography. The colonoscopy can be 6 years old. I mean, you don't have to be quite as aggressive. So that's a little bit relaxed. So fundamentally, the thing here is, in general, if you just look at the run-in, instead of almost 2 months till actual treatment in angstrom, this is really 1 month or less, and that's the huge difference. So from when I identify a patient, such as I did on Monday, that would be a potential candidate for this study, actually, sorry, that was Wednesday. He and his family are meeting me on Tuesday to discuss enrollment, and within 2 weeks, I could have him into enrollment. So much, shorter run-in. Also, just to be clear, the angstrom. So the other thing with that is, just for people, the idea of transporting cells across state lines requires, federal licensing, and a lot of, even Cornell and Columbia didn't have that. So that trial was just very cumbersome.
So it was part of the problem on the disease progression over 2 months.
So the patient becomes ill or sick, and that's still true. I mean, this population, there are patients who you think are going to get in the trial, and then they develop pneumonia, and they end up in the ICU and pass away. I mean, they're sick patients. All these trials suffer from a high, the Data Safety Monitoring Board has to look, and a lot of the patients are quite ill. But that portion is still, this one's the easiest that I've been involved in of 6 of them, 7 of them, to get patients into and to run.
Okay, and then you just mentioned that you saw a patient that was perhaps too far gone, even for the study. So across multiple sites, 'cause how many sites are involved in the study again? Did you say that?
This is
About 40.
Yeah, this is 40 internationally.
40 internationally.
15 in the U.S. 15 in, yeah, 15 in the U.S. Yeah.
50. So how do you control for uniformity in patient evaluation across the different sites? In other words, at what point will one patient say in Israel say this patient's too far gone? Will it be the same time that the doctor in the U.S. will say this patient's too far gone?
Well, there is difference across. You are right. There is difference across countries, and some countries have different, therapeutic windows. And choosing the right site can be difficult. You're absolutely right. One of the things that happens, of course, is if you're at a tertiary center and someone gets sent to you from, if someone from Buffalo sends a patient to me because of this trial, and I don't put them in the trial, that becomes an issue, and that can occur in certain sites and countries. But there are very strict guidelines and criteria here, and we have had international meetings and groups, and I've spoken to some of them, and some of the key opinion leaders are certainly European. And the idea there is there's fairly good guidelines in regards to what's a salvageable limb. And I mean, we go back to the sort of the Rutherford idea that Rutherford 6 is not a candidate for this. And none of the trials, and I think you're very aware of this, none of the trials they've shown that Rutherford 6, those patients go on to get amputated and die. And Rutherford 4, truthfully, a lot of those folks, it's not as clear. So Rutherford 5 is really the sweet spot. Minor tissue loss and malperfusion. And that group gets to a criteria that is pretty uniform across the world. It's not just that they have no intervention option. And that's the bigger difference. The bigger difference is not the patient itself, but should we try an intervention? And that can slow things down because you have to have failed an intervention at least 2 weeks ago before enrollment. So if you try, sometimes I might look at something and say, I'm not doing anything. Someone in Poland might say, we're going to do something. Both fail. I can get them in 2 weeks. So that's going to be a bit of a variable, but it's a much more uniform.
Okay, and final question. Thank you for showing the data of the wound healing. That really sort of brings home the point. I presume those are some of your better performing patients, but it is a randomized trial, and you are getting some patients that aren't in the PLX-PAD arm. So I presume you're also seeing a proportion of patients, maybe 1/3 out of all the patients that don't heal and keep progressing. Is that
of course, we're actually not reviewing it at that. We can select and say, oh, these are nice pictures. But if you start to review, as you know, if you start to do any sort of interim analysis, that's a data question really for, I'm not on the data safety monitoring board, obviously, but that's a data safety monitoring board really question if anything seems to be out of proportion. And of course, they can theoretically unblind the data if they have to. But that's not, I don't think we're deep enough into it to get a sense yet. But of course, we expect a certain proportion of these patients are expected that they have a known amputation rate, they have a known mortality rate. I'll just say my experience with that, having sat on one of these trials, DSMBs, not for this company, but another one, is we actually did end up unblinding the data to make sure, and no, it turned out that at a 2-to-1 randomization, actually you can say it was Harvest, but the 2-to-1 randomization, when you looked at it, it matched correctly. People who were getting a signal weren't doing as badly as the control arm, but we getting concerned because a lot of deaths and a lot of amputations. We're like, but it turned out that's what happens to the folks.
But we can say that according to what we see globally, we are in line with the protocol assumptions.
Well, thanks for answering that loaded question.
Hey, Michael Acunos from Maxim Group. So I was wondering if you could talk about how the phase 2 results in intermittent claudication stack up to some of the other treatments out there, like antiplatelet agents, which have demonstrated some benefit.
Well, yeah, it's interesting. Well, not to counter Manu, but the antiplatelet agents, I mean, so the phosphodiesterase 3A inhibitor, right, Platal, I mean, that's not really, it has a little antiplatelet effect. That obviously can increase the walking distance, and that's a long-term, lifetime therapy. You take a pill twice a day, rest of your life. Associated with about 7% intolerance. About 7% of patients just can't take it. 1% get tachycardia, and another 7% get intractable headaches or so. With that in mind, as far as the straight antiplatelet agents and all, if you take a look at the European literature and the American literature, in general, there's no increase in walking distance. Actually, smoking cessation has no increase in walking distance. Walking has an increase in walking distance, right? So getting people to modify their lifestyle, unfortunately, in the U.S., we've taken away any sort of coverage for that. Monitored walking is what helps, not just telling people to walk. That's been shown to make no difference, and that's what we're left with in the U.S. So I think that, to me, unfortunately, as a clinician, a lot of patients come in and they want a treatment. I can say you're 340 pounds, you have sleep apnea, have you had a study for that? Can you get your diabetes under control? But they'd like an injection or they'd like a pill, right? That's what medicine pays for to some degree. But if you take out lifestyle modification, because it's been shown to work, but it's not applicable to many folks, as a specific, as a standalone treatment, now of course that's just out at 6 months, that data really. You expect that that's going to, be very interesting what that's doing at 2 years, because that will be really the the guts when it comes, can look at the back at some of these patients, say, 2 years ago they got 2 injections and they're still walking so much better. But as an initial signal, I think the main thing for me is it says in a difficult, in a disease that's not that severe, this makes a big difference in how patients perform. We've got the right dose anyway. And we should, again, just from general studies, we should make a much bigger difference. And this is why we don't do bypasses on patients with claudication, right? It improves their perfusion, but not their quality of life. So they improve their quality of life. They improve their oxygen tissue, tissue oxygenation, and they improve their walking distance. And so a bypass wouldn't do that. So for me, it's an actual potential change in their physiology.
And then what would be the next steps in intermittent claudication? Would it be like a phase 3 trial? And could you potentially use some of the data from CLI in support of a total data package and maybe get a shortened pathway?
So for now, we are moving forward with the CLI study. The primary goal is to have these clinical studies approved as soon as possible. We believe that since we did a relatively large phase 2 study in IC, we will be able to have some discussion with the FDA for potential expansion of the label for additional peripheral arterial disease. But the primary goal for now is to continue with the CLI and to wait for the data and then to integrate it with the IC.
All right, thank you very much.
Thank you.
Okay, there's a couple of questions from the webinar. I just wanted to put them out there. One related to what we were just discussing for Dr. Lantis. You presented the data from the phase 2 IC study. In your opinion, how supportive is this data to the pivotal CLI study? And how well is it a predictor for the success? And then the other question is for Yaki. You talked about non-dilutive financing, but what is the overall financing strategy of funding your PAD clinical pipeline?
So just to answer the question, I think I just answered the question pretty much the same way. In fundamentally, lesser disease with an actual change, again, in the physiology of the tissue. I think long-term data will be even more supportive because this, again, the idea of maybe a cure here or a very intermittent treatment. And just to point out one thing, I think one of the other reasons that I'm very supportive of the company pursuing CLI is, it's always interesting from a researcher, a clinician standpoint, obviously unmet clinical needs. So claudication, you could argue, you can treat a couple different ways, as your question alluded to, right? And there are maybe some therapies and lifestyle, and it's not so severe, right? So but this is really an unmet need, and this is an area where we know that we have really strong data that says, right off the bat, 15% of the population we can't do anything for. Another 20% we probably shouldn't be doing some of the things we're doing. So as a caregiver, I'd much prefer to have something. So there's a much bigger delta here, benefit to be found in CLI. And then I think from a clinician perspective, just like everything else, we can move backwards and say, oh, well, this patient would benefit from this too, or we can modify your life. I mean, if you're a 54-year-old and you know you have an increased death rate, but you possibly could get an injection, maybe that would be a person who you'd say, maybe it's not even a covered entity, but maybe you could actually say, you should pay for this. So I see there being a big difference that way down the road. But
And as for the question about the financial strategy for PAD, we worked very hard in the last few years to bring quite a lot of non-diluting funding to the company. And that was one of the primary goals that we identified. And as we were able to present, the CLI study, a substantial amount of money of it is funded by the Horizon 2020, by the Israeli government. We're going to, one of the main goals for 2019 is to attract additional non-diluting funding that, from one hand, will allow us to hold the assets, but on the other end, will provide the money that is needed for the clinical studies. We see a lot of support, we see a lot of interest, and that will be the primary goal for that. Financing is a big issue. We're seeing the last few weeks all over the markets, especially for Pluristem, and that's something that we are looking at very, very, very seriously. Pluristem it's never been in a better position, as I mentioned, moving the study, running forward. We're getting a lot of appreciation, a lot of achievement in the last few weeks, in the last few months, and this is what we'll continue to do. We strongly believe that this is what needs to be done in order to bring the value for our shareholders. Since we're holding manufacturing, since we're having all this licensing agreement for technologies in place, we're having this expanded access. Pluristem is very attractive partner for also for looking at government level or healthcare system that have interest in what we do. And we will, I believe, we're able to capture a lot of funding for this important PAD program while creating significant value for our shareholders. So the coming months are extremely interesting for us. And as you saw the pipeline, we are heading the markets. And that's a goal, to bring this product to the market as soon as possible.
Are there any? Okay.
Thanks, George Zawajko again. Yaki, this is for you, talking about the manufacturing. We use a 3D method of manufacturing, and that is somewhat maybe even completely unique to you. Maybe you can answer that question first. And second, with that kind of technology, you clearly can make a whole lot more cells in much fewer space than 2D stacked flasks. Have you thought about using that as a contract manufacturer for other companies for their cells as a non-dilutive funding and source of revenue?
Thank you. So the three-dimensional or the bioreactor, it's actually really a key competitive advantage for us, no doubt. We have over 200 patents in assets protecting this technology and its capabilities, and that's the difference between science and a drug. Okay, the three-dimensional, the bioreactor, will actually allow us to bring this product to the market. So that's a key competitive advantage. From day one, we think of marketing. And the reason that, and we're having this discussion on a weekly basis, because a lot of companies are approaching, why don't you manufacture it for us? It doesn't make sense. We invested 12, 13 years in this project of developing these technologies, over $250 million. We hold the key of a competitive advantage of being really a leading player in this industry. I'm looking at the markets. I'm not looking at clinical studies, but I see what's going around. This technology will allow Pluristem to be the key player in the regenerative medicine and to control the markets or to be the most active player in the industry because we can manufacture. That's the difference. So it doesn't make any sense in our stand to give this advantage to competition right now. Definitely, it creates a lot of interest. And like doing a contract manufacturing it's like potentially an easy money, but the way that we see that, it's a wrong decision. We rather enter to additional agreements, we either do a licensing for non-core technologies like with Chart or with Thermo, but we do want to keep our competitive advantage. That's the thing that's gonna make us a real big company.
Okay, thank you.
Hi, Susan Switzer. I had two questions. One may be a little naive, but just in terms of the drug itself and the treatment, is there any sort of a long-term study? I mean, you treat at the site, you potentially get these wonderful results, but the underlying disease state that all these patients have hasn't really changed. So is the expectation that, 5 years down the road, whatever it is, if these patients survive, that this problem reoccurs and the treatment needs to happen again? And then I have a totally different question.
Well, I mean, that's again, agreed, the huge question, and it isn't answered so far. There's, the problem also becomes that even the short-term animal models for this disease process are very problematic. There aren't great models for this. I mean, I spent a long time ago creating arteriosclerosis in monkeys, and that takes several years to do before you can study anything on them. At the moment, we know that these patients have costly reinterventions, and many states are limiting the number of angioplasties or bypasses. Like Maine, for example, you can do one thing that year for a patient because we're doing things sometimes 3 times in a year. So it would certainly seem that that's not going to be the case based on the early studies. The question is, do you have a real modification? Historically, some studies in this area that are phase 2, not even with different products, have shown increased life expectancy and some other signals, but they haven't ever played out for a variety of reasons in the phase 3 trials. So I think we're yet to see that. The hope, the thought here is that this actually does cause some actual remodeling of the tissue. Again, that idea of, to some degree, a cure, where you'll see either longer times between various interventions or longer times between treatment. But as far as being known, and the company folks can correct me if I'm wrong, but I mean, there's no animal model that's going to tell you that, and we don't have enough data yet to tell us what that signal looks like.
And is the plan then to study these patients on a very long-term basis once the trial is sort of completed to figure out if you get that or not? That's really not part of the
We
equation
did design this study that part of the population, we're going to have up to 3 years follow-up. So that's something that will be able to provide a real long-term data set. And we agree that it's important. Looking at the general healthcare spending, that's important. So we're going to have this part of the population or part of the patients will have a long-term follow-up.
And the separate question is, if I sort of guesstimate from the chart you showed about potential revenues, it looked like about $250 million the first year. I'm looking at your estimate of sort of 25,000, 35,000 per dose. That's about, I guess, 10,000 patients, if I'm doing the math right. Can you give a sense of how this product is going to need to be sold or distributed? I realize you don't have it yet, but just in terms of thinking about the cost structure of how many people you need to reach and to get a patient population of that size and potentially much larger.
So actually, we do have the model. We work hard on it because we are seeing the market. So we cannot respond when we're having the BLA in place. We did develop a full cold chain supply. So from a logistic point of view, we have several warehouses here in the US that are actually maintaining these drugs. And when, if Dr. Lantis has a patient and he wants to enroll them, it's just going to ping into the system, and there's going to be an automatic dispatching of this product to the site. So this is a system that it already exists. They're able to serve actually hundreds and hundreds of patients here in the US. Of course, also in other places like Europe, Israel, and elsewhere. So logistic-wise, cold chain-wise, we are all set. We do think that initially, all of our estimations that if we can approach a relatively small number of patients, and you saw this gigantic market, but even 10,000 patients are generating a substantial amount of revenues to the company, and we do target that. We are having, of course, the discussion whether we should try initially to approach them by ourselves or to use post-BLA marketing agreements. Both options are valid, and we're going to do whatever is best that we're going to create the best value for our shareholders.
So, I mean, whether you do it yourself or go to somebody on the outside, approximately how many salespeople do you think are needed to service just the US, let's call it?
It's too early to discuss, but this is not a very big number. Based on all the estimations that we provided so far, we are looking at very few dozens, if at all. So it's not a very big sales force, because each and every site are serving a relatively large number of patients.
Okay, thank you for all the questions here in the room and online. Ariaki, would you like to wrap up?
I would like to thank all of you, so many people here in the room, and our guests on the webcast. And please continue to follow the company, and thank you for your interest. Appreciate it. Have a nice weekend. Thank you.